Welcome back to Exploring the Spectrum. Today we have with us Claire Sehinson, who is a late diagnosed autistic, ADHD, and dyslexic researcher, functional medicine trained practitioner, and educator. She creates resources, teaches, and advocates for people with chronic illnesses or invisible disabilities, in particular those that co-occur with neurodivergence and others who are underrepresented in clinic and research. Welcome to the podcast.
Thank you, Julia. So excited.
So for context, I first heard about your work because I took your course with Psychiatry Redefined. And as I was listening to everything you were saying, it started to really shape how I view some of the patients that come into our clinic who have chronic pain. So that's why I reached out to them. I said, can you please connect me to Claire? And I want to share this conversation with the listeners because I think it really broadens the lens for providers and also individuals who've been experiencing kind of what we'll be talking about, this medical gaslighting. Yeah. So to start, can you share about how you got to do the work that you do?
Yeah, absolutely. So a little bit convoluted, but I worked for a chronic fatigue, a specialist MECFS clinic, and also chronic pain, fibromyalgia. And we tended to work with quite complexly ill people using functional medicine, psychology, nutrition, kind of lots of different interventions. And there were probably a subset of these patients who were just, in spite of all their efforts and doing all the right things, they just weren't making any progress. Some of them were getting worse and worse and worse. And rather than looking at them as, there's something wrong with you not doing the interventions correctly, I just really started to think, what if the interventions are just not fit for you and your neurotype? And it kind of simultaneously, I started to have a lot of difficulties myself because I have a history of having chronic fatigue and repetitive burnout. And in spite of my knowledge, I at best could function daily and kind of mask and do my clinical role, but I would get repeated burnout and chronic fatigue and all sorts of things. So I started exploring things myself and ended up with a dual diagnosis within 3 months of each other, which was a lot to take on, of both autism and ADHD. And that just kind of, it was very life affirming, but also I had a complete kind of identity shift in that time. And then really just started looking at all the interventions I'd done on myself. A lot of it was functional medicine, was natural medicine, psychology, all of these things that I had been applying to fix myself, and starting to see the flaws in those interventions. And, it's kind of just massively eye-opening. So I was having this honest conversation with a lot of my clients at the time, and a lot of the kind of more difficult cases turned out to be neurodivergent too. So yeah, it really kind of got me thinking, we're trained in the systems medicine and, it's kind of it's different to allopathic medicine that we do think holistically, we do think in systems, but it's still a lot of the protocols that we have are not really fit for people with these different brain styles. So I really had to go through this journey of unlearning everything. So that was quite difficult to do in clinical practice because I had protocols to follow and I really believed in the medicine I was providing. But it was kind of unlearning, relearning, and then looking everything through this neurodivergent lens. And I started to see shifts in some of my really, really long-term difficult, like very gravely ill, complex illness patients. So that was kind of how I came to thinking we needed a course like the one that I did for Psychiatry Redefined, just to reimagine like what healthcare could look like and raise more awareness and teach. So I've kind of been on that mission since then to kind of help practitioners out, because I know a lot of supervision I do with practitioners they are at their wits' end. They really want to help people. They just they weren't trained in the right tools to recognize all of this. So yeah, that's kind of how I end up in this kind of intersection or niche. But yeah, absolutely love it. And it was shocking to see how there was nothing there was no information available. There are a few people in the field doing the groundwork, but yeah, very, very little support out there. So, yeah.
So you mentioned that you had your diagnostic journey. and it helped you contextualize what you were doing for yourself. How could somebody who doesn't have that experience learn? Like, do you think that contributed to your ability to look at people with this lens? And how can somebody do that if they're not themselves neurodivergent?
Yeah. So the way I look at it is kind of sort of through a disability lens. So when I understood about my neurodivergence, and I was really kind of understanding neurotype, so it's really you kind of, I think, in medicine or some of the training I've done, it's referred to as a triple empathy problem, or maybe I'll go back one step and explain double empathy. But when you look at sort of autistic people, for example, and allistic, so non-autistic people, there are just a lot of cultural and communication differences that might mean they might misunderstand each other, or they might have different versions of empathy, and that can lead to a lot of miscommunication, misunderstanding. So we kind of, I think a lot of practitioners understand that, and that brings some of the fear, but it's kind of approaching that with curiosity. Just kind of, even saying, how does your brain work? And just asking why, rather than just assuming that it's wrong and needs to be changed or fixed. You could just go, oh, so why do you do it like that? And what does that do for you? So that's a really simple way of just understanding another culture or human. The triple empathy is where you add that layer of medicine, because medicine is its own culture. So it's like another culture. It's got its own language. It's got practices. It's got its own kind of things that we do that, even non-medics wouldn't really understand. So when you add that layer, it kind of adds this whole, additional complexity on top of things. So you could be trying to explain how you're sensing things, and then trying to explain that to a medic who's then got to decide whether you need an intervention or not. And it's kind of like a double kind of cultural difference. So that, I think, is where a lot of people or practitioners get stuck. So I think, like a lot of us, we're taught how to communicate medical terms in more layman's terms to non-autistic people, because that's the medical training and that's the language and what we've been trained to recognize. But no one really understands how to explain that maybe to an autistic person. And this comes from autistic doctors. I've spoken to autistic doctors, and we're all trained in the kind of allistic medical model. And we can kind of have this incongruousness with our own feelings. So, for example, migraines. I've had migraines since I was a child, and I didn't know they were migraines until I was about 30, because I thought, you should have kind of some sort of vascular headache, and you might get an aura, and that's not how I experienced migraines at all. So I actually didn't know what was wrong. I thought I was disassociated. I thought I was having a panic attack. I thought I was allergic to something, and I couldn't convey that to anyone who understood. And it was only kind of realizing, okay, I'm having a sensory type of migraine, and ocular migraine. It's completely different. And then I had to then educate my doctor about that presentation, and they completely agreed. But it was kind of like, okay, so I've had this my entire life, and I've never been able to have appropriate help for it. So yeah, I think for practitioners, I guess, because every neurodivergent person is also different. So not every autistic person will get a migraine in that way. So it's just a recognition that we all experience things in diverse ways. And we're kind of only trained in what the majority might experience. So it's not writing it, I guess, keeping an open mind when we're doing investigations with our clients, and not kind of rushing to label something, and just being as thorough as possible and being open-minded. And then also believing someone's testimony about what they're experiencing. So that's kind of my top tip, I guess, in working with people who might have these differences.
And basically what you just described, the practitioner could apply this to everyone, because
yeah.
I think in medicine, and it's the brain likes patterns, and it tries to be efficient. So many providers will be like, oh, treatment-resistant depression, I know what this patient is like. So with autism, you can't really do that and be effective. Mm-hmm. But the question is, can you do that and be effective for that treatment-resistant depression patient if you're just assuming things about them?
Yeah. And I think any treatment resistant condition, um, I flagged that for potential neurodivergence because we have a lot of people that have these atypical reactions to medications or therapy. So people that say, I cannot do meditation. It gives me panic attacks. It gives me, kind of, I feel disassociated. We would have those kind of clients. So we were used to it in our clinic. But I think no one really knew what to do with that information, but we just had a lot of people that had tried everything and nothing was working. So we had to keep trying new things. And yeah, I think it's the treatment resistant conditions in particular make me think, well, it's probably not the right intervention. We just need to keep looking and there will be something that suits your neurotype. You're pretty lucky if you kind of try one thing, a medication, and it works and it makes everything better, than great. But I think the reality is with chronic illness, it's never been like that for me. Yeah.
What are some of the chronic illnesses that you've seen much more commonly in neurodivergent populations?
So I would say a lot of it is related to this neuroimmune system. So you'll see things like chronic fatigue syndrome, long COVID. I think it's backed by both research and clinical practice. Things like chronic Lyme disease, autoimmunity is really common, lots of GI conditions, but so both the inflammatory bowel, but also the IBS, quite severe IBS syndromes. I would say almost everything under the immune dysfunction umbrella. So that will include things like mast cell activation, and large amount of things that are technically not recognized. So whenever you see things that are not fully recognized as a medical condition, things like burnout, so it might be lumped under the chronic fatigue umbrella, but we see a lot of fatigue related illnesses and kind of things like that. Disordered eating is really common, really, really, really common. I think I think what's getting a lot of attention is the post-viral illness and mast activation at the moment. I think there's a lot more recognition, whereas it wasn't as well understood. I think COVID, that's the one thing that COVID's really highlighted, who's vulnerable to long COVID.
In our past conversations, we touched on the interoceptive differences that exist in these populations. Can you share about just interoception and what those differences are and how that contributes to medical trauma?
Yeah. Okay. So with interoception, the brief kind of 101. So it's a science of how we feel our feelings and also how we interpret body signals, how we assign meanings to those signals and how we use that information to then give our body what it needs. It's part of this self-regulation cycle. So with the interoceptive process, it's a sense for a start, and we can sense physiological needs like, am I hungry? Do I need a wee? Am I tired? Am I cold? Am I hot? And it's also part of our kind of affect. So do we feel uncomfortable? Or do we feel safe? So safety is a feeling. So all of these feelings, our body's giving us, like, constantly pooling this information from receptors throughout our body and sending those signals through the vagus nerve to different parts of our brain. But there's a particular area of the brain called the insular cortex that is known to be kind of bariocentrally involved in interoception. And then our brain then decides, right, what could this mean? Does the butterflies in my stomach mean that I'm nervous, or am I hungry, or am I, random meanings for some people? And what am I going to do about it? So in someone who has really good interoceptive function, they can do that with like a high degree of accuracy. So if they're too hot, they know about it. If they're anxious, they know about it and they can do something to regulate. In neurodivergent people, it's been shown that we have poorer interoceptive function, and there can be problems that happen at any part of that. So it could be the sensing, that's the issue. So differences, we can have heightened interoception. So people might relate more to the clinical things like having a really sensitive gut. So if their diet slightly changes or the textures of their food, or, in some cases, I've had people that say that cereal brand that I've been eating for 20 years, there's an ingredient that's different, I'm not going to eat it anymore. So they can have really, really heightened interoception, and kind of they're sensing their system a lot more strongly than people who have kind of a neutral interoceptive function. You can also have a very, very low interoceptive function where you could have, so I've had people who haven't realized that they're in pain. So they've, until it's an absolute emergency. So they have turned up to an emergency room with like a twisted bowel. They've kind of, people would have said, you know, how did you not notice anything earlier? And they just didn't. They didn't sense anything. So it could be the sensing that's different. It could also be the being able to verbalize or assign meaning to what those signals mean. So you could be feeling those signals quite strongly, but your brain might not be able to correctly assign what's going, like label what it is. So I have a lot of people. So when it's related to emotions and feelings, this is called alexithymia. So alexithymia is part of interoceptive difficulties. But you could be, you know, kind of in a lot of discomfort, but you just can't really kind of pinpoint or verbalize what's going on. So it's like saying, you know, we start most conversations like, how are you feeling? Well, people with alexithymia cannot answer that. They just no idea. But they could be feeling something quite strongly. So there could be something in the processing of that information that they're having difficulties with, or it could be the self-regulation part. So it's like, great, you've got the signals up there, you've interpreted it. Now what are you going to do about it? And some people don't, they don't have the attention or the executive function to be able to regulate themselves. So, yeah, we can see it's really complex. It sounds like just, can you feel your feelings or not? But it's actually quite a complex process, and we can have problems with any part of that. But that whole kind of area of research is looking at what's linked to a lot of things like mental health difficulties, chronic pain, addiction, substance misuse, and eating disorders. So it's a big upcoming area of research. I think the second part of your question was, how does it link to potential
medical trauma?
Yeah, so imagine you're a doctor and someone sits in your office and they go, something's wrong, I don't know what, or I'm just in a lot of pain, or I just feel disgusting and toxic. And you're like, well, how? And can you describe it? Like, no, I just feel horrendous. Or they could not look like they're in pain, but they could be feeling, so that's often with autistic people, our facial expressions and body language might not match our level of discomfort. So it just looks incongruous. And then medics can often underestimate the level of like severity of our symptoms. So yeah, with a lot of my clients, they might have gone to healthcare providers looking for help or asking for help, and this kind of communication difference, or this difference in the way our brains are processing information and this inability to verbalize what's going on, that can lead to like a misdiagnosis for a start, or missing a diagnosis, or just not being believed. So a lot of people, especially late diagnosed adults that I've worked with, who maybe have a collection of health, kind of mental health and physical health labels already, they might go to the GP and the doctor, you know, kind of asking for help. And a lot of their symptoms could be put down to anxiety or being melodramatic. There's all these kind of horrendous explanations I've heard. Rather than giving someone access to care and follow up, they've just been told, well, it's part of your autism, or you're just really anxious, it's stress, and that starts this trauma, just not being believed. Other people, it's this kind of epistemic injustice. So it's like a testimonial injustice, where because you're seen as a hypochondriac, or you're seen as overly sensitive, you're suddenly not a credible source of describing your own body state. So whatever you say literally doesn't matter. And I've had a lot of patients where they will not go back to their GP for anything. So like, do not make me go there. I'd rather go straight to A&E if there's a really grave problem, but I'm not going to my doctor. So it does lead to kind of increased earlier mortality. It's quite a serious problem in our group, unfortunately.
And there's something else about this, because in medicine, we're really not trained to work with autism. Even in pediatrics, there wasn't much that I was taught that was effective or
Yeah.
useful, even in like a clinical setting. And I think for a lot of physicians, that uncertainty makes them, if somebody comes in with a diagnosis of autism, and physician or mental health provider, they might actually tell this person that I'm not qualified to work with you, which compounds the issue of access to care, because now these are underserved populations, and it's because we're not trained. So if we're not going to get it in our schooling, how do we get providers caught up now, other than sending them to your course, which I'll add in the show notes?
Yeah, of course. I mean, I think nowadays, luckily, I've seen quite a few books and kind of written by medics, written by psychiatrists who have a real understanding of autism as a whole person. So I think our training, because I was also trained under that model, and I always say this to people, I did my master's dissertation in autism, and the language and everything I wrote in there, I just think, oh my God, it just, I can't even read it, because it was just a completely different narrative to what I know now. But I think the narrative that we're trained in, so this medical model of autism, it does generate a lot of fear for both the practitioner, because it's seen as a very scary, kind of confusing, and it's based on stereotypes of autistic people who are in distress, and there's no complete picture of what it's like to be autistic, or what it's like on the inside, and what the strengths are, and what autistic joy looks like, and kind of just stereotypes people down to their worst characteristics or when they're in distress. So unsurprisingly, because so much of research is done by non-autistic people, kind of looking at autistic people as a thing, like observing them, it will never have a real understanding of autism. And that's why, in short, why the training's kind of useless, because they're effectively just looking at, but what it's suggesting is there's a very narrow band of how brains are supposed to work, how senses are supposed to function, how bodies are supposed to work. And if you don't fit in that, it's medicine's job to come and fix that. And when you're kind of applying that to autistic people, it's completely wrong. So I think even the goal of medicine, like people often approach autism like, I really want to fix all your traits. And that's not what anyone wants. You want to live really well as an autistic person. If you have disabilities, you just want to be enabled in society. And there are a lot of things that we are vulnerable to. So understanding our health vulnerabilities would be much better training, I think, so we can be supported from an early age rather than have a lifetime of stress that compounds every system. So I think, just this shift in the narrative, I think if it would be so beneficial. If one thing were to change, like one paradigm were to change, I'd want autistic and ADHD and every neurodivergence just to be seen as a whole, and to be understood, and to be understood that it's not wrong. We just have a different way of thinking and being in the world and existing and sensing, and understanding that life is not really set up to support that. So it creates tension, stress, burnout, the masking's exhausting. And if all of that were understood, and taken into account in medical terms, I think, it would be a great start. Yeah.
What you said about the classic picture of autism is an autistic individual at their worst. And I think about people in general, like nobody is their best self when they're triggered.
Yeah.
And to be viewed at your lowest moment as like, that's who you are, in and of itself could be so terrible that you wouldn't want to go to any provider.
Yeah, absolutely. I mean, so many people who I've spoken to who recognize themselves as being autistic or ADHD, a lot of people, because of the medical trauma and because of how they've been treated and the stigma, for whatever reason, don't want to seek an official diagnosis. And I totally understand. I think it's more when they can identify with autism as a whole and the culture and understanding their identity with if they don't need a diagnosis on top of that, because especially in this country, in order to access specialized services, you do need a diagnosis, or with ADHD to access medication, you would need a formal diagnosis, which in itself, that process is hugely stressful, but it kind of depends on what that person's needs are, the level of, I guess, impairment in society and functioning. It's kind of, there's a lot of people who will never go near a diagnosis, but they don't feel like they need it to be validated as a neurodivergent person. Yeah.
Do you have a way to educate autistic individuals on how to advocate for themselves or how to navigate medical systems that might need them to be a little bit more expressive of their pain in order to believe them?
Yeah. I mean, when I work with clients, we sort of speak to their practitioners and we often advocate on their behalf. So we'll be sending letters out. We'll talk about their communication preferences and we'll kind of affirm things through a neurodivergent lens. So the areas of most tension, for example, where a doctor might not believe that person or might say, well, that's depression or that's gut issues. They might say, well, I've ruled out this and this, and I don't think that's a thing. We'll always try and help them to educate their doctors through explaining, why their nervous system might be impacting their gut function and why we believe, explaining our rationale behind the protocols that we're giving. So we do try to support them. With patients themselves, because a lot of GPs, like we always say, you can get a second opinion. So we always say, if you've got someone that is absolutely causing a lot of trauma and stress, it's not helping you at all to be speaking with them. So we kind of give general questions to their medical provider and say, maybe, have you worked with neurodivergent people before? Like a good question is, what do you know about autistic people? So when they start listing DSM criteria, it's like, run. So when they, if you're boiling down a whole group of people down to like, here's the DSM criteria, it's kind of, you don't know autistic people. When some of them will say, actually, my brother's autistic, or I have a friend who's been late diagnosed, because a lot of medics do know. There's a lot more awareness now and a lot more training. Compared to when, I was younger and learning. But we kind of do a little screen to see what's their narrative about autism. And I would say 9 times out of 10, that's gone really well. And the person might have the fear. They might not really understand how to support people, but they'll at least be compassionate and they'll be careful about the language used and kind of, flag the person that they might need more different kind of styles of communication or some of the sensory needs being met. So there are guidelines for mainstream practitioners. I think maybe the 1 in 10 where they're like, everyone's got autism these days and like there's all of these things. Like some of us will give them a script of things to say and studies to cite to show that, kind of to debunk a lot of myths, because there's so many myths that still haven't died out yet about neurodivergence in general. But I would say the majority of medics I've spoken to these days tend to be kind of more affirming, and it's thankfully a lot better understood.
What are some of the myths that you see are still holding strong?
Oh gosh, actually, quite a lot of them. I think a lot of them, there's still growing understanding of the intersection. So like neurodivergence in females. So a lot of my female patients might struggle to, or they might have to over-explain or over-rationalize why they need to be put forward for an autism diagnosis. So they're like, well, you make eye contact, you've got friends, you don't like trains or whatever the stereotypes are. So that's the kind of thing. The questionnaires don't help because they need a massive word update or at least different examples, I think, because they are validated in young boys. So when you get like an adult female trying to get an ADHD diagnosis and it's kind of saying, do you like jumping on furniture? Maybe, but I think most adults don't relate to that. So it's kind of, I think it needs a bit of an update. So a lot of people of colour might struggle to also obtain a diagnosis if you don't have the money, if you don't fit that kind of stereotypical young white male, kind of which the DSM criteria is based on. It can be hard and you can be misdiagnosed, you can be misunderstood for years. So it typically takes a longer time to get a diagnosis. So for example, autistic females and ADHD females take much longer. I think it's at least 3 to 8 times longer to get a diagnosis. You tend to have to meet a higher threshold of symptoms compared to young white males. And this is all perpetuated by the myths of what people think autism looks like, because of, it's not been helped by the media, by that whole Rain Man kind of imagery that a lot of doctors of a certain age will have. I think there's more representation now in media of the whole spectrum. So I think people are, slowly debunking those myths, but I think there's still a long way to go. I like to say it's getting better, but I think for some groups it's not. There's still a long way to go.
And you've mentioned marginalized groups before, and I've heard a term autigender. Can you share anything that you've seen in your clinical practice just about gender identity and autism?
Yeah, I mean, there's a huge overlap with different intersections. So we tend to study everything in isolation. So here's the research on autism, here's a research on kind of the gender spectrum and trans folks, and here's the research on other marginalized groups. But when you think about it, if I'm a woman, Asian person, queer, identifying, disabled, that's all going to impact how my neurodivergence presents and is recognized and how I am in society. So they're all going to kind of synergize and create impact on my identity and my stress levels and my levels of privilege in society. So you can't really separate everything out. So the understanding the intersections really understands that those layers, I guess, the compounded minority stress that can really impact people. When we look at things like gender and autism or LGBT groups and autism, if you're trans, you're more likely to be autistic. So there are studies or surveys that back that up. Same as if you're autistic, you're more likely to be in LGBTQ. So there is huge overlap in the groups, and it tends to be the people that are most marginalized that have all these intersections and don't have access to support or appropriate support. They tend to be underrepresented. Like if you look at eating disorders, for example, higher incidences in autistic people and also in the LGBT population. Yeah.
The eating disorder aspect was really interesting because as children, there may be texture preferences or, like the bland foods, like the tan diet. And if a provider is not aware of the potential that this is an underlying autism diagnosis, they may treat them, the eating disorder clinics and all of those other things that now create a whole slew of other traumatic experiences because it was never about the eating disorder. It was sensory. It was something else going on.
Yeah. I mean, we see a lot of that. And I mean, before 2013, before the DSM-5 was published, we didn't even have ARFID as a diagnosis. So it's avoidant restricted food intake disorder. I have adults now who have ARFID and it's seen as a pediatric condition, but like these people were kids at one point, and it is so interlinked or connected to someone's sensory preferences. So I think sensory issues in food, because eating is such a sensory experience, which is why, there's so much kind of restaurant marketing and science around it. But it's, again, like with everything else, we're supposed to like 10 different colors on our plate and all these different textures. And for some people, that is just too much information for them. And that can result in some sensory overload. For those of us who have retrained and understood sensory differences in autism and also safety, and this kind of, when you're in this really unsafe, stressful situation, like a transition, like a, kind of life transition, you might want to pare back all this information overload. So a lot of people have a sudden onset change in feeding behavior or food preferences. They might only want to eat 2 different types of food, and that can be massively pathologized. And it's instantly the panic of, right, we need to intervene, we need to force feed people, and without really understanding what the function of that was. So that was that person's natural instinct to keep themselves safe, to reduce that information overload. So I think, with eating behaviors as well, that's another really Western colonial thing, because we're, especially nutrition, which I trained in, we're kind of all taught to, the Mediterranean diet is like the top ranking thing that we could do. And we need to all be balancing our blood sugars and maxing out the protein. And actually, you're not really, it's boiling everything down to its nutrients and not really understanding the function of eating and the function and the sensory aspects of that. And, there's so much more to eating food than just filling your body with fuel. So this kind of direction that nutritional science has taken, I'm not loving it, if I'm honest. It's way too obsessive over certain nutrients and not really understanding the role food has for people. It's memories, it's safety, it's kind of, grounding, it's culture. So, I think this kind of approach to disordered eating, which is a whole debate and conversation, which I won't pull us into, but this kind of idea that there's a right way to eat and there's a wrong way to eat. And, in spite of what your body is saying, you must override that and eat this way because that's good for you. I just don't think that's a healthy approach to working with someone.
You mentioned earlier these medical protocols, and they're intended to help a majority, but the averages don't even include the whole population. Exactly. They oftentimes don't include women. Yeah. There's no separation for this is a neurodivergent subset of the population. Maybe they respond differently. So it's just kind of trying to average things. And you mentioned nutrition. I see this in the biohacking world. There's all of these protocols, and I think it's great to have this information, but what we're still missing is the invitation to ask ourselves, how does my body feel when I use this protocol? How does my body feel when I supplement my nutrition in these ways? And we just keep outsourcing the things that are supposed to come from inside. Great to have the info, but how do you know if it's actually working for you if even your providers aren't asking you the right questions?
Yeah, exactly. I think our clinic went for a bit of an evolution of particularly when you've got a condition like chronic fatigue. And there's a lot of mitochondrial research, what we should be feeding our mitochondria, and the whole burnout research, what they should be eating. And there was a phase it went through where it was very paleo keto. So that was a bit of a trend. And the thing is, one of the clues is it's part of this diet culture, because whenever there's a trend in medicine, when there's trending things, and it's this week it's keto, next week it's paleo, it's like, that's not a thing. That's diet culture kind of masquerading as medicine or biohacking. So biohacking is just a form of diet culture, in my opinion. It's a trend, but it's complicated because our clients come to us because they want us to use the best research to our knowledge to try and support them. A lot of people who are chronically ill, whether they're neurodivergent or not, they could be complexly ill, or they could have a lot of trauma, CPTSD. Their interoception is going to be affected. So more often than not, you kind of go, does this feel good to you or not? And they don't know. And they'll just go, I'll do whatever you say to just get me better, because that's the dynamic, that's a hierarchy that people assume they're coming into when they come into a clinic. It's like, you're the medic and I'm the patient, and I'm the paying person and you're the person meant to be giving me information. So that is the typical dynamic, and we try to level that out because they know their bodies best. So we might be having early conversation. We might be saying, I'm not going to give you a diet. I want your body to know whether this is good or bad for you, whether you like this or not. What do you need? Because I can't just give you a thing, an off the rack book and say, read that, and this, your mitochondria will love it. And because that just makes no sense to me anyway. So a lot of it's reconnecting them. And because the majority, you'd have seen the research of chronic fatigue and long COVID, and there's a lot of kind of overlap with trauma, chronic trauma. So a lot of people, when we're doing this interoception work and we're reconnecting them with their bodies, it has to be a slow process because it's quite traumatic to suddenly go, can you just get in your body and let me know what it wants? Because they've spent their lifetime having, kind of all of these, maladaptive responses to kind of disassociate. So it's a really slow process in reconnecting them with understanding their body signals for a start. But then we'll also do education, because a lot of them will want to know, we'll run labs. They'll want to know kind of, right, So I've heard about this diet, tell me about it. So we like it when people do that. They're like, I've been on Reddit and I've read this is good, this is good, and this is good. And we'll have a chat. So we'll have a conversation and we'll give that person the information and the autonomy for them to decide then what they want to do. Because we have done the other approach before we all kind of slowly shifted towards this model. And it was putting people on a very strict keto diet or a paleo diet or a SIBO diet or a mast cell activation diet. And it just made them sicker and more sensitive. And maybe they'd have a short-lived, like, I actually feel a bit better. And then something else would kick in and it's just not sustainable. So that was our experience with it. And we're like, okay, now that's not working. Like, what am I going to do? And we find that when we kind of reconnect them, so it's kind of like a similar to the intuitive eating model. But to even apply that, you kind of need good interoceptive function to know what feels good and what doesn't feel good. So a lot of the early work is building that trust with their own bodies, building interoceptive function, giving them the tools to feel safe, which a lot of them don't, which is why you can give them the best stuff in the world, the most expensive supplements, and it's not going to work because their bodies are not safe. So it's going to do some sort of danger response. So early work is really working on that felt sense of safety, trust, and then leveling that. I'm not going to tell you what to do. I'm going to tell you things and you're actually going to tell me. So you see this shift in dynamic. I think it's a bit weird for some because they did not expect that. So there's a lot of tears, like, I feel validated, I feel listened to, but that's what we want. We want to validate people. We want to believe people. So many people come in apologizing, saying, I don't know how to describe this, but I just feel really wiggly and wobbly and, like vibrating. And you go, yeah, cool. I get that. That's really common. And they're just confused why we know why that would even accept those descriptors. But that's absolutely, the language that they need to use. So I guess enabling them with whatever they need, whether it's language, the language that works for them, the kind of protocol that works for them, because there are, as you know, in nutrition, 101 thousands of different things that you could do that's supposed to work for every condition. So we're really just working on their individuality and taking into account the sensory environmental things, because they play such a big part. They sound like a little thing, but there actually is everything, really. And when they have that and they have their safety toolkit, they can then implement things. So my favorite thing is when people don't need me anymore and they just check in, they go, okay, I had a post-viral flare, but I did this and this. Do you agree? And I was like, perfect. I wouldn't change any of that. You just know that they've learned the tools for themselves. So yeah, it's all about kind of connecting people to their tools. Yeah.
You mentioned earlier that it wasn't until 2013 that the DSM had updated, and one of those updates was sensory challenges became part of the diagnostic criteria, which it never was before. It was always focused on the mental, behavioral.
Yeah.
But if lights are too bright and sounds are too loud, your body's going to be in this constant stressed state. And we know the effects of chronic cortisol. And I imagine working with your clients and even getting them to realize what are the things that feel good versus feel bad, and then building that toolkit, that can be validating and give them so much more information about how they got to where they got to.
Yeah, absolutely. It's interesting you mentioned like the 23rd where the criteria changed, because before we're so focused on external behaviors. And I think the sensory element was the first time it kind of thought about them on the inside and like what's happening internally. I like thinking about it like you've got this external presentation, but a lot of people use so much effort in hiding that external presentation because they know the stigma, or they've learned that there are ways to be in society that's acceptable or not. So all of that effort that goes on putting on this facade, whereas this recognition of the internal wiring being different, I think that was a huge thing. So I've had people that might have been diagnosed Asperger before that got collapsed back into the autism spectrum. So I have a few clients, and just the way they think about themselves and talk about themselves is so different from people who are diagnosed post 2013. I just found that really interesting. And it's kind of saying it's actually okay to be like that. It's not bad. But they've just been told there's something wrong with me. And, I think before 2013, it was like weird sensory. It was just the language was like unusual or bizarre sensory experiences. it's not bizarre. It's just a spectrum. Some people have heightened sensory. I've got a friend who she can drink a cocktail and she can tell you all of the ingredients in the cocktail. They could be random things of like, that's a bizarre sensory experience, but it's like fairly useful. Yeah. So it's kind of, I just think the narrative shift, and also kind of the other conditions like PMDD or RFID that have now been recognized since 2013, it's giving maybe a more complete picture of kind of a lot of our sensitivities and vulnerabilities in health. So hopefully there'll be better understanding, less medical gaslighting of like, that's not a thing, or you just got bad PMS, or just work harder to cope with it. Like, I just hope in the future, no one has to deal with that anymore, that attitude.
Yeah, when you have already had negative experiences with the medical space and you find yourself in a position where, okay, but I do need medical help, to go in and not find the words for what you're trying to express and then be invalidated on top of that, it's going to make you feel so much more alone. And the mental health challenges that we hear oftentimes with autism, I'm sure it compounds. And it's like, okay, let's get the medical industry caught up a little bit so that we can stop this.
Yeah. A lot of people just feel hopeless, I think, and just don't want to interact, which is why so many people end up quite severely ill, because the only time they'll present in a medical setting is when it's kind of an emergency. So it saves lives to listen to patients, to kind of validate people, to believe what they're saying. And I think just in the chronic illness community and disability community anyway, it's kind of one of the principles is just believe what people say. If they say they're disabled, if they say they're struggling, believe them, rather than, kind of, I'm not sure what people would gain of saying, well, no, you're not. Like, you're just depressed, or you're just stressed. I mean, like, they are stressed, but it's not just stress for a lot of people. They could have a serious health problem that could potentially be supported. So yeah, we need changes, don't we? Faster than they're happening.
I could probably talk to you for 3 hours because there were so many other points about, the menopause. I think maybe I could have you back on to talk about that, actually.
Yeah.
But do you have any words of advice for providers when it comes to working with neurodivergent populations or chronic illness in general?
Yeah, I would say, and this is kind of where research is heading, listen to people of that identity. So don't go back in time and look at textbooks which are basically quite outdated, a lot of that research. You'll get a lot more from asking autistic people, looking at autistic testimonies. A lot of autistic-led research, for example, is done by autistic researchers, autistic doctors, and they are interviews with autistic people who are talking about their lived experiences. So a couple of interesting ones. There is a menopause one. So it talks about autistic menopause and how that can be experienced in a different way. And a lot of people didn't realize they were going through the menopause. They found it more distressing because they were unaware they were autistic at the time, and they were experiencing things differently. Same with the autistic burnout research. It's a lot of structured interviews that talk to people about their burnout. And that's where they realize actually different things stress neurodivergent people out. Well, that's different to, kind of neurotypical people, or we experience lots of different things as stressful. So what causes or triggers trauma in autistic people can be very different to non-autistic people, or what's even in the DSM is listed as what can cause trauma. So I think, just listening to people with lived experience, more research from people with lived experience, which it kind of tends to be happening a lot more now. So look at those sources. You can usually tell the second you start reading a paper because they will use a different language. It's a completely different experience reading autistic-led research for me as a researcher than if I'm reading a paper by someone who isn't autistic, because I feel incredibly triggered when I read certain things about my behavioral problems and my kind of unusual traits, whereas it's an entirely different experience. So I think, that's what I would say if you're allistic, you're non-autistic. listen to autistic people, listen to disabled people, chronically ill people and their testimony. I think things like long COVID, a lot of that research came from the patient population, and understanding all of those symptoms, you'll get the most useful out of information from people with lived experience.
Yeah, as you're talking, this idea of if someone tells you that it's hard, don't make them prove it. Ask them why or
Yeah,
ask them what.
exactly. That's perfect. I mean, we need a list of these things, because I think a lot of practitioners have asked me, like, I just want to help. I'm not really sure how to ask questions because it's so different from our clinical thinking and our pattern recognition, because we can't do it, but we don't understand it. But yeah, it's similarly, if someone says I don't want help, then trust that they don't, because I have had clients go to doctors and they haven't helped them with the thing that they've gone with, but they've told them, oh, like, you're struggling with this, and they're like, I'm really not. Because they just want to do something. So yeah, just believe people when they talk about themselves, I think.
Where can people find you to either work with you as a client or learn more from you as a provider?
I would say at the moment, probably my website. I'll give you, I think it's clairelizasehinson.com.
I'll add it in the show notes.
Yeah. And I do have an Instagram, which I'm planning on doing more free resources on there. So it's Neurodivergent Health Advocate, but I'll send you, like, we can find those in the show notes.
Perfect. Thank you so much, one, for the work that you do, and two, for joining to share this, because more people need to know that things are shifting. And it's really amazing that you're able to give a voice to so many people who have been disempowered by a system that was meant to help them.
Oh, well, thank you. It's been such a great conversation.
Thank you so much.